Welcome to our introduction on economic evaluation in public health. Economic evaluation is a crucial tool in public health. It's a comparative analysis of the costs and outcomes of different interventions. The goal: to inform resource allocation and improve efficiency in healthcare. Imagine a balance scale. On one side, we have the money spent, on the other, the health outcomes achieved. Economic evaluation helps us ensure that the scale is balanced, maximizing health benefits for every dollar spent. When conducting an economic evaluation, we can perform either a partial or full analysis. A partial evaluation only looks at one intervention, while a full evaluation compares multiple interventions. Here's an example of a cost-benefit analysis, one type of economic evaluation. In this example, the benefits of $140 billion outweigh the costs of $6 billion, resulting in a net benefit of $134 billion. To summarize, economic evaluation compares costs and outcomes of interventions, informs resource allocation decisions, and aims to maximize health benefits per dollar spent. This critical tool helps decision-makers choose the most efficient and effective health interventions. In economic evaluation, accurately determining costs is the essential foundation. We categorize costs into direct and indirect costs. Direct costs are directly attributed to the intervention, such as medications, staff time, and supplies. Indirect costs include productivity losses and secondary effects. When determining costs, we must consider different perspectives. The healthcare provider perspective looks at costs of providing services. The patient perspective considers costs of accessing care. The societal perspective includes costs incurred by all parties. To accurately capture all costs, we track resource use throughout the entire patient journey or intervention process. This includes staff time, equipment usage, medications, and facilities at each step. Once we understand individual costs, we can perform a budget impact analysis. This examines how implementing an intervention affects the overall healthcare budget by comparing the current situation to the projected new situation. To summarize, effective costing requires comprehensiveness, considering the right perspective, accounting for the timing of costs, and maintaining transparency in methodology. The ingredients approach is a systematic method used in economic evaluation to identify all resources needed for a health intervention. This approach involves meticulously listing every resource used in an intervention and assigning a unit cost to each one. Let's examine the key resources that typically need to be identified and costed in a health intervention. First, we need to account for staff time, which includes all personnel involved in delivering the intervention. Medical tests are another important resource, including all diagnostic procedures required. Drugs and medical supplies must be itemized with their specific quantities. Equipment used in the intervention should be included, with costs appropriately amortized. Finally, facility costs cover the space where the intervention is delivered. In practice, healthcare costs can vary significantly between different interventions. This graph shows cost differences between two comparable treatments. As healthcare costs continue to rise, detailed resource listing becomes increasingly important for managing budgets efficiently. Healthcare funding flows through various channels, and the ingredients approach helps track how resources are allocated across the system. Let's look at a practical example. For an HIV testing campaign, we would need to list all required resources. By identifying each resource and assigning appropriate unit costs, we can calculate the total cost of the intervention. This detailed approach ensures nothing is overlooked in the economic evaluation. When conducting economic evaluations in public health, there are two primary approaches to costing: top-down and bottom-up. Top-down costing, also known as gross costing, allocates a total budget to specific services using general formulas. Bottom-up costing, or micro-costing, involves a detailed analysis of all resource use changes at the individual service level. In top-down costing, we start with the total budget, such as a hospital's annual budget of $10 million. This budget is then allocated to different departments based on predetermined formulas or historical patterns. In contrast, bottom-up costing starts by identifying and valuing each individual resource used in providing a service. For example, to cost a COVID-19 test service, we would list each component: test kits, technician time, protective equipment, and overhead. Each resource is quantified and valued, then summed to determine the total cost per service unit. Let's compare these two approaches side by side. In top-down costing, management provides a budget that flows down to teams. In bottom-up costing, teams provide input that informs management's budget decisions. Both approaches have distinct characteristics. Top-down costing is less time-consuming and requires less detailed data, but may miss important variations in resource use. Bottom-up costing is more precise and better captures true resource use, but is more resource-intensive to conduct and requires detailed data collection. This visual representation shows how top-down costing starts with the big picture and is management-driven, while bottom-up costing starts at the operational level and is employee-driven. When deciding which approach to use, consider your needs and constraints. Use top-down when quick estimates are needed or data is limited. Use bottom-up for novel interventions or when precision is critical. In practice, many evaluations use a mixed approach. Let's apply costing methods to a real-world example, an HIV testing campaign. Many HIV testing campaigns use mobile units to reach communities. These units contain all necessary equipment and provide privacy for testing and counseling. First, we need to calculate the costs of testing supplies, including HIV test kits, gloves, alcohol swabs, and documentation forms. Next, we must account for staff costs, which include testing technicians, counselors, and program managers. Finally, we need to include operational costs such as vehicle maintenance, utilities, communication, and required permits. Now let's summarize all the costs for our HIV testing campaign. Our cost summary includes the main categories and their associated amounts. Testing supplies cost $12,500. Staff costs are the largest expense at $45,000. Operational costs amount to $22,500. We also include overhead costs at 15%, totaling $12,000. Adding all these costs gives us a total program cost of $92,000. This total cost is then used as the foundation for further economic evaluation. For example, in cost-effectiveness analysis, we can calculate the cost per HIV case detected. In cost-utility analysis, we might determine the cost per quality-adjusted life year gained from early HIV detection. Or in cost-benefit analysis, we can compare the monetary costs of testing to the monetary benefits of prevented infections. Cost-minimization analysis, or CMA, is a specific type of economic evaluation. It's used when comparing interventions that have been proven to deliver equal outcomes. In other words, the health benefits are exactly the same. In this approach, we're simply looking for the cheapest option among interventions that are equally effective. In this example, both interventions produce the same health outcomes, but intervention A costs $100, while intervention B costs only $80. Since both interventions provide the same health benefits, the CMA approach would recommend intervention B as it's the more cost-effective option. The CMA formula is straightforward. Choose the intervention with the minimum cost, given that all outcomes are equal. Let's look at a cost comparison of 4 different interventions. Each has been proven to deliver the same health outcome. Using cost minimization analysis, we would select intervention B, which costs $80. It's the cheapest option while providing the same health benefits as the others. This graph shows the cost effectiveness of various interventions in global health. For interventions with equal outcomes, CMA helps identify the most affordable options. CMA should be used when outcomes are proven to be equivalent, when quality of life impacts are identical, and when cost is the only differentiating factor between interventions. In healthcare, CMA might be used to compare different diagnostic approaches that lead to the same clinical outcomes. For example, comparing branded versus generic medications that have identical effectiveness. Despite its simplicity, CMA has limitations. Rarely are outcomes exactly equal. It may oversimplify complex healthcare decisions, and other economic evaluation methods are often preferred when outcomes differ even slightly. Cost-Minimization Analysis, or CMA, is particularly useful when comparing interventions with equivalent health outcomes. Let's apply CMA to a practical example, choosing between generic and branded drugs. When both drugs have identical therapeutic effects, CMA tells us to select the less expensive option. Generic and branded drugs have several key differences and similarities. Generic medications contain the same active ingredients and are equally effective as their branded counterparts, but typically cost 80 to 85% less. For generics to be considered therapeutically equivalent, they must meet strict FDA criteria. These include being pharmaceutical equivalents, bioequivalent, properly labeled, and manufactured according to good manufacturing practice regulations. The cost savings from choosing generics can be substantial. This comparison shows how generic drug prices vary across different pharmacies. Notice the significant price differences for the same medications. Let's apply CMA to antiretroviral therapy, where both generic and branded options exist. With this table of antiretroviral medications, a health economist would compare the costs of therapeutically equivalent options. To summarize, when applying cost minimization analysis to drug choices, if two drugs have identical efficacy, we should choose the less expensive option. In the case of antiretroviral therapy, selecting generic drugs when available allows healthcare systems to treat more patients with the same budget. Cost-Effectiveness Analysis, or CEA, is a method of economic evaluation that compares the cost per natural health unit. This approach allows us to understand how much we're spending to achieve specific health outcomes. CEA measures the cost required to achieve a specific health outcome, expressed in natural units. Natural health units are outcomes that can be directly measured, such as infections averted, life years gained, cases detected, or hospital days avoided. The basic formula for CEA is the cost-effectiveness ratio, which divides the cost of an intervention by the health effect achieved. For example, if a tuberculosis screening program costs $100,000 and detects 50 TB cases, the cost-effectiveness ratio would be $2,000 per case detected. Results from cost-effectiveness analysis can be visualized on a cost-effectiveness plane, which helps decision-makers interpret the findings. The plane shows the relationship between costs and effects. In the northeast quadrant, interventions are more effective but also more costly. In the southwest quadrant, interventions are less effective but also less costly. The other quadrants have clear dominance relationships. Let's look at how CEA is applied in practice for program evaluation. This graph demonstrates a threshold analysis showing how program offerings are evaluated against cost-effectiveness thresholds. Programs on the left side of the threshold are offered, while those on the right are not, based on their cost-effectiveness ratios. Cost-effectiveness analysis helps decision-makers allocate limited healthcare resources to maximize health benefits across populations. The basic formula for cost-effectiveness analysis compares the difference in costs to the difference in effects between interventions. This formula calculates the incremental cost-effectiveness ratio by dividing the change in costs by the change in health effects. The formula can also be written as the incremental cost-effectiveness ratio, or ICER, which shows the additional cost per additional unit of health benefit. The CEA formula helps us understand how much extra we need to spend to achieve one additional unit of health benefit. Let's look at an example comparing two drugs. Drug A costs more but saves slightly more lives, while drug B is much less expensive per life saved. In practice, CEA often uses decision tree analysis to compare multiple interventions and determine which provides the best value for money. This basic CEA formula is essential for health economists and policymakers to prioritize interventions that provide the greatest health benefits within limited budgets. In public health, we often need to compare different intervention strategies to determine which provides better value for money. Let's examine how cost-effectiveness analysis can be applied to malaria prevention through bed net distribution programs. Among various malaria prevention methods, insecticide-treated bed nets have proven highly effective in reducing transmission. Let's compare two different strategies for distributing insecticide-treated bed nets. Strategy A involves community-based distribution, where health workers distribute nets directly to households. Strategy B distributes nets through health facilities when people visit for routine care or treatment. To perform our cost-effectiveness analysis, we need data on the costs and health outcomes of each strategy. Strategy A costs $100,000 and prevents an estimated 500 cases of malaria by distributing 10,000 bed nets. Strategy B costs $80,000 and prevents an estimated 300 cases of malaria by distributing 7,000 bed nets. The cost-effectiveness ratio is calculated by dividing the total cost by the number of malaria cases prevented. For strategy A, we divide 100,000 by 500 cases prevented, giving us $200 per case prevented. For strategy B, we divide $80,000 by 300 cases prevented, giving us $267 per case prevented. Let's visualize the comparison. A lower cost per case prevented indicates better cost effectiveness. Our analysis shows that strategy A is more cost-effective at $200 per case prevented, compared to $267 for strategy B. Even though strategy A has a higher total cost, it delivers better value by preventing more malaria cases at a lower cost per case. This demonstrates how cost-effectiveness analysis provides an objective criterion for making resource allocation decisions in public health. Cost-utility analysis is a type of economic evaluation that compares the cost per quality-adjusted life year gained from different interventions. The key feature of cost-utility analysis is that it measures both the quantity and quality of life, making it especially valuable for healthcare decision-making. Let's compare cost-utility analysis with other economic evaluation methods to understand what makes it unique. Cost-utility analysis has several important applications in healthcare decision-making. These include evaluating different types of health interventions and determining their optimal magnitude. The formula for cost-utility analysis is straightforward. We divide the cost of an intervention by the quality-adjusted life years gained. When conducting a cost-utility analysis, it's important to perform a full economic evaluation, comparing the new intervention to existing alternatives. A partial evaluation that only looks at a single intervention can lead to misleading conclusions. To summarize, cost-utility analysis is valuable because it measures outcomes in quality-adjusted life years, incorporates both length and quality of life, allows comparison across different health areas, and is widely used for healthcare resource allocation. Quality-adjusted life years, or QALYs, are a key measure in health economics that capture both the quantity and quality of life. This graph illustrates how QALYs work. The yellow area represents additional quality and length of life gained through an intervention, compared to the blue area without intervention. Disability-adjusted life years, or DALYs, measure the overall disease burden as years of healthy life lost due to illness, disability, or early death. Here's an example showing how DALYs are calculated for Jan, who has tuberculosis. His DALYs include both years lived with disability and years of life lost due to premature death. Let's compare QALYs and DALYs side by side to understand their key differences. These measures are essential tools in economic evaluation. QALYs are typically used in cost-utility analysis to compare interventions across different health conditions. Both metrics help decision-makers set priorities for resource allocation and measure disease burden in populations. These measures rely on accurate data about disease incidence rates, how frequently new cases occur in a population over time. The cost-utility analysis formula incorporates quality of life into economic evaluation. The CUA formula is defined as the incremental cost divided by the incremental quality-adjusted life years gained. This measures the additional cost required to gain one additional quality-adjusted life year. Delta cost represents the difference in costs between the new intervention and the current standard of care. Delta QALYs represents the difference in quality-adjusted life years between the new intervention and the current standard. Let's look at a detailed example of QALY calculation with and without treatment. This example shows how a treatment increases both survival time and quality of life, resulting in a QALY gain of 4.5 at a cost of £4,000 per QALY. The cost-effectiveness plane helps visualize where interventions fall in terms of cost and QALY gains. Points below the threshold line represent cost-effective interventions, while those above exceed the willingness to pay threshold. Let's work through a practical example of CUA calculation. Consider a new treatment costing $50,000 that provides 10 quality-adjusted life years. The standard treatment costs $20,000 and provides 6 quality-adjusted life years. The incremental cost is $30,000. The incremental QALYs gained is 4. Therefore, the cost-utility ratio is $7,500 per QALY. Cost-utility analysis is an economic tool that measures intervention consequences in terms of both quantity and quality of life. The outcome is expressed as the intervention cost divided by QALYs gained, allowing comparison between different healthcare interventions. Section 5, Cost-Benefit Analysis, or CBA. Cost-benefit analysis compares total costs and total benefits, with both measured in monetary terms. What makes CBA distinct from other economic evaluation methods is that it requires converting health gains into dollar values. Let's compare CBA with other economic evaluation methods we've discussed. Here's a visual example of cost-benefit analysis. In this case, we see benefits valued at $140 billion and costs at $6 billion. The analysis shows that benefits outweigh costs, resulting in a net benefit of $134 billion. A key challenge in CBA is monetizing health outcomes. There are several approaches to converting health gains into monetary values. Converting data to monetary values is crucial for CBA. This allows us to directly compare the financial value of health improvements against program costs. CBA facilitates decision-making by allowing direct comparison of diverse health interventions and across different sectors. Cost-benefit analysis helps build decision frameworks like this one, where the monetary value of each outcome can be calculated and compared. The cost-benefit analysis formula is straightforward but powerful. CBA equals total benefits minus total costs. This simple equation forms the basis of cost-benefit decision-making. When the total benefits exceed the total costs, the intervention is considered economically beneficial. We can visualize this as a balance scale. When benefits outweigh costs, the intervention creates net value. Cost-benefit analysis helps determine if a decision is economically sound by comparing all its costs and benefits. Let's see how this formula is implemented in practice. A related metric is the benefit-cost ratio, which divides the total benefits by the total costs. A ratio greater than 1 indicates a beneficial intervention. Decision trees are often used in cost-benefit analysis to evaluate different options. Each branch represents a possible outcome with associated costs and benefits. Let's look at a concrete example of cost-benefit analysis. This decision tree shows how we can evaluate different strategies by calculating expected values based on probabilities of various outcomes. To summarize, when applying the CBA formula, we systematically compare the monetary value of all benefits against all costs. Remember, an intervention is economically beneficial when the total benefits exceed the total costs. Cost-benefit analysis allows policymakers to make evidence-based decisions by systematically evaluating the economic impact of different options. Cost-benefit analysis applied to flu vaccination programs allows us to evaluate their comprehensive economic value. When analyzing a flu vaccination program, we first identify the program costs, including vaccine procurement, administration, staff training, cold chain logistics, and management of potential adverse events. On the benefits side, we quantify reduced healthcare costs, avoided hospitalizations, prevented deaths, reduced work absenteeism, and increased productivity. Cost-benefit analysis aims to weigh all costs against all benefits expressed in monetary terms to determine if the program has a positive net value. The economic burden of vaccine-preventable diseases like influenza is substantial. A single flu season can cost billions in medical expenses and lost productivity. The CBA formula is straightforward. Net benefit equals total benefits minus total costs. If the net benefit is positive, the program is economically justified. Flu prevention strategies are multifaceted. Vaccination is the primary intervention, but other preventive measures also contribute to reducing the economic burden. Let's consider a real-world example. For a flu vaccination program targeting 1,000 people, the total costs might be $30,000. The benefits include $25,000 in avoided healthcare costs and $15,000 in productivity gains, totaling $40,000. This results in a net benefit of $10,000 per thousand vaccinated, with a benefit-cost ratio of 1.33 to 1. An often overlooked economic impact is presenteeism, where employees come to work while sick. This reduces productivity and increases disease transmission, adding to the economic case for vaccination programs. In conclusion, cost-benefit analysis provides a comprehensive framework for evaluating flu vaccination programs by monetizing all costs and benefits to determine their overall economic value. The Incremental Cost-Effectiveness Ratio, or ICER, is a crucial metric in economic evaluation. It helps us understand the additional cost required for each additional unit of health outcome gained when comparing different interventions. When comparing two interventions, we need to determine both the difference in costs and the difference in health outcomes. For example, if intervention B costs $800 and provides 12 quality-adjusted life years, while intervention A costs $500 and provides 10 quality-adjusted life years. The incremental cost would be $300, and the incremental effect would be 2 quality-adjusted life years. The incremental cost-effectiveness ratio is calculated by dividing the incremental cost by the incremental effectiveness. In this example, the ICER is $150 per quality-adjusted life year, meaning we pay $150 for each additional QALY gained. The incremental cost-effectiveness ratio can be visualized on a cost-effectiveness plane. Each quadrant of the plane represents different relationships between costs and effects. The threshold line represents the maximum society is willing to pay for an additional unit of health outcome. Economic evaluation, and the ICER specifically, helps us balance costs against health outcomes. The ICER is essential for comparing the relative value of different interventions. Lower ICER values indicate more cost-effective options. The decision threshold for what constitutes an acceptable ICER varies by country and context, but it provides a framework for rational resource allocation in healthcare. The Incremental Cost-Effectiveness Ratio, or ICER, is a crucial metric in economic evaluation. ICER measures the additional cost required to gain one additional unit of health effect when comparing two interventions. The ICER formula is defined as the difference in costs divided by the difference in effects between two interventions. Breaking down the formula, the numerator represents the additional cost of intervention 2 compared to intervention 1, while the denominator represents the additional effect or health outcome gained from intervention 2 compared to intervention 1. Here we can see the standard ICER formula clearly expressed. The variables C1 and C0 represent the costs, while E1 and E0 represent the effects or outcomes of the interventions being compared. Let's look at a practical example. When evaluating a new hepatitis C therapy compared to an old therapy, the ICER formula calculates the additional cost per additional quality-adjusted life year gained. The ICER tells us how much additional money needs to be spent to gain one extra quality-adjusted life year with the new therapy compared to the old one. Ultimately, ICER provides a standardized way to compare the value of different interventions across healthcare, helping decision makers allocate resources efficiently. In this section, we'll visualize the incremental cost-effectiveness ratio using TB screening algorithms as an example. On our cost-effectiveness plane, the x-axis represents effectiveness measured as TB cases detected, while the y-axis represents costs in dollars. Let's plot two different TB screening algorithms. Algorithm A is less costly but detects fewer cases, while algorithm B is more expensive but more effective. The incremental cost-effectiveness ratio, or ICER, is calculated by dividing the difference in costs by the difference in effectiveness between these two algorithms. In our example, the cost difference is $4, and the effectiveness difference is 4 additional cases detected. Geometrically, the ICER is represented by the slope of the line connecting the two algorithm points on our cost-effectiveness plane. In this case, the ICER is 1.0, meaning that each additional TB case detected by switching from algorithm A to algorithm B costs an extra $1. This visual representation helps decision makers understand the trade-off between cost and effectiveness when choosing between different TB screening strategies. Throughout this series, we've explored various economic evaluation methods for public health interventions. We've covered 5 key methods: costing, which forms the foundation of all evaluations; cost-minimization analysis; cost-effectiveness analysis; cost-utility analysis; and the incremental cost-effectiveness ratio. Economic evaluation guides the efficient use of limited health budgets. As shown in this cost-effectiveness analysis, programs A and B have benefit-cost ratios greater than 1, making them valuable investments. Economic evaluation plays a crucial role in the budget process. From formulation to oversight, these methods ensure resources are allocated to interventions that provide the most health benefit per dollar spent. A full economic evaluation, as illustrated here, compares alternatives rather than simply looking at a single intervention. This comparative approach is essential for identifying truly high-value interventions. By applying these economic evaluation methods, public health professionals can identify and choose high-impact, high-value interventions. This systematic approach ensures limited healthcare resources are used efficiently to maximize population health outcomes. In conclusion, economic evaluation provides a structured framework for making difficult healthcare resource allocation decisions, ultimately leading to better health outcomes for populations. As we conclude our exploration of economic evaluation in public health, remember this fundamental principle. Cost-benefit analysis tools help quantify both financial and public health benefits, allowing you to make data-driven decisions. When applying economic evaluation, remember these key principles. Apply appropriate costing methods. Choose the right analysis type for your question. Consider multiple perspectives, and always prioritize high-value interventions. Economic evaluation provides a structured approach to comparing interventions, enabling you to make evidence-based decisions that maximize health outcomes with available resources. Economic evaluation can be applied in numerous ways: prioritizing prevention programs, allocating limited healthcare budgets, justifying funding for public health initiatives, and comparing different intervention strategies. Health impact assessments provide a systematic process for evaluating potential health effects of policies and programs, complementing economic evaluations to ensure comprehensive decision-making. Remember, by applying economic evaluation principles, you ensure that every dollar spent contributes to the greatest possible improvement in public health outcomes. Always weigh costs against outcomes, seeking the optimal balance that delivers the highest value for your public health investments. By making informed, evidence-based decisions through economic evaluation, you can make every health dollar count.